So first of all, I just want to welcome everybody and give you a short introduction to our hosts. There's 3 hosts. We're all board members of the Florida Advocates for Behavioral Health organization. First, me, I'm Amy McClellan, and I'm the board president of Florida Advocates for Behavioral Health. And I'm just a volunteer advocate in the behavioral health field. Our first co-host is Maggie DeCambra Borges. She's Vice President of Operations for Behavioral Health and Program Director at Florida HCA Whitt Hospital. She's also a board member of Florida Advocates for Behavioral Health and a board member of NAMI Broward County. And we also have Gail Giese. She's president of the Florida Mental Health Advocacy Coalition, which is our sister organization. Also a board member of Florida Advocates for Behavioral Health and of the Florida Supportive Housing Coalition, and a mother of an adult child with mental illness.
Yes, Maggie DeCambra Borges, pleased to be here. Let me tell you a little bit about the Florida Advocates for Behavioral Health. We are a new nonprofit organization that's dedicated to helping Floridians understand how Florida's behavioral health system works and how to advocate to make it better. Florida Advocates for Behavioral Health is a learning community with the mission to educate citizens on the behavioral health issues and policies to improve the lives of individuals and families living with behavioral health conditions, while at the same time decreasing stigma through increased understanding. Just want to take a moment also to let you know we are a 501c3 organization, nonprofit, and that we all donations are certainly deductible as qualified charitable contributions. We're very grateful today to our sponsors. We have 2 sponsors, Newport Healthcare and Alchemies. Just want to make a disclaimer that please note that the views expressed by the speakers in the webinar do not necessarily reflect those of the Florida Advocates for Behavioral Health. And moreover, Florida Advocate for Behavioral Health does not endorse any treatments or therapies as expressed by the speakers.
Okay, so all of us who are involved in Florida Advocates for Behavioral Health, at least on the board, have very personal experiences related to behavioral health. And we've also experienced barriers and gaps in the system. And for me, it started when my daughter was 13. And she told me that she had bipolar disorder. And I looked at her and I said, oh no, that can't be true. That sounds really serious. And in fact, I didn't really know anything about it. But she was right. And there were actually some signs since she was 4 years old that she was a little different than other kids. She had explosive behavior at home at times, but these mood swings really didn't happen very often and they didn't affect her schoolwork. So we just dealt with it at home. But then at age 14, her extreme mood swings basically took over her life and she couldn't function at school. She couldn't function at home, and her relationships with her friends were sort of crazy as well. And we really didn't have any idea what was happening, even though she had told me. And first I thought it was drugs, something to do with drugs, but it wasn't. She was first misdiagnosed by a child psychiatrist and given medication that actually caused her to spiral into really dangerous hypomania. And eventually, about a year and a half later, we got the right diagnosis. But then the psychiatrist tried different combinations of medications, and there was really nothing that could help her function. Like either she was sleeping all day, or she couldn't think clearly, or she was extremely agitated. And she really was trying to keep up with the medications, but nothing was really allowing her to function. And I was really frantic. There was very little information about pediatric bipolar disorder. And in fact, a lot of professionals didn't even want to admit that it existed. So it was really hard at that time to find out more information. And it was also hard when you have a child or an adolescent to keep them in school because school is very inflexible. And she was experiencing rapid mood cycles. And we were also very afraid that she was going to hurt herself, and she was hurting herself. She had some suicide attempts, and we were also worried that she was going to hurt us because there were a few times that she did hurt us, not too badly, fortunately. And so I started to look for some kind of a residential program for her. And there really wasn't anything for her age that was really suitable for what was happening to her. In the end, this is sort of to sum it up, it took 10 years to find the right medication for her to enable her to actually function. And a lot of bad things can happen in 10 years, and they did. And I'm just very thankful that she's alive and she survived. And some of the gaps that we experienced included, at that time, there were zero resources in school for a teenager who had bipolar disorder. There weren't any guides or directories on children's mental health services. This has changed, fortunately. And there wasn't an appropriate treatment setting for her to just be in a residential care so that she could be observed over time so that her medications could be tweaked. And there's also an abrupt transition from the children's mental health system into the adult system. They're completely two different systems. And when a person passes at the age of 18, it's as though they're like different people all of a sudden, but they're really just the same person experiencing the same things. So, although many things have improved, there's a lot more information available, we still have some hugely significant gaps that let people fall through the cracks. And that's what we're going to be talking about today with our expert panelists.
Thank you so much, Amy, for sharing your story of your journey with your daughter with us. Everyone really who has experienced behavioral health challenges or who works in the field knows that there are significant gaps in the system of care, but they've actually never been properly mapped out in a systematic way. So today we have an opportunity with our expert panel to review the gap analysis that was done.
Yeah, so what is the gap analysis? Back in 2025, SB 330, the Behavioral Health Teaching Hospitals Bill was passed. And within this bill, there was the requirement for a detailed gap analysis of the state system of care that was to be contracted by the Department of Children and Families to another independent source. And so the DCF contracted the company Ernst Young. They had a fairly short time frame to do this analysis, and they had to collect a lot of data and produce the report and present it to the Commission on Mental Health and Substance Use Disorders in January 2025.
So the recovery journey, Johnson & Johnson slide, here's a visual of what a complete behavioral health system of care might look like to someone who has schizophrenia. The recovery journey is not a straight line for everyone. There are detours and exits and are different for each person within the system of care. The important thing, however, is just that no one falls off the road during this journey and because of barriers to care or gaps within the system. So we're presenting this webinar because we really believe that everyone involved in the behavioral health system can use this knowledge to advocate, to fill the gaps, and to make some real significant improvements. It's important for our legislators to understand what the gaps are in the state system of care and in their local community-based systems. We also think it's very important for everyone to agree upon what should be included in an effective behavioral health system. Amy, I think we are at slide number 8 to talk a little bit more about this to our panelists.
I'd like to introduce our first two panelists, and we'll introduce Sheriff Purnell a little later on, our very special guest panelist. Kathleen Moore, Dr. Kathleen Moore, is a research professor at the Department of Behavioral Health Practice. Sorry, I'm getting this wrong. Behavioral Health Science and Practice at the University of South Florida. And she's also the executive director of the Louis de la Parte Florida Mental Health Institute at the University of South Florida. And she has collaborated with numerous agencies with a focus on program evaluation, bridging the gap between research and practice for such issues as mental illness, co-occurring disorders, homelessness, child welfare, and jail diversion. And she's also the chair of the subcommittee for data analysis with the Commission on Mental Health and Substance Use Disorder. And Courtney Whitt, Dr. Courtney Whitt, is the first executive director of the Florida Center for Behavioral Health Workforce in the College of Behavioral and Community Sciences at University of South Florida. Dr. Whitt specializes in integrated primary care psychology for traditionally underserved populations, as well as associated administration, research, and policy. And she is interested in developing best practices for creating access, collaboration, and leveraging and expanding the continuum of behavioral health care while reducing workforce and administrative barriers to this end. So we're really happy to have you both. And Kathy, you can take it away.
Thank you so much, Amy, for that introduction, and thank you all for allowing us to present with you. It's such an important topic, and happy to kind of break down a little bit the gap analysis, and then to really talk through what are some of the recommendations and what can we do now and in the future to really improve the state of Florida's behavioral health system. So I really like the title, Minding the Gaps, Addressing Gaps in Florida's Behavioral Health System. So as I think Maggie mentioned a little bit about the gap analysis, but just to dig a little bit deeper, the study included information on several different indicators, such as current bed allocation, and this is broken down between both adults and children, admission and discharge, average length of stay by facility, the program type, current and projected demand for civil and forensic inpatient placement, bed needs, and that was broken down by facility and placement type, and then length of stay for Medicaid statewide inpatient psychiatric services. The analysis also examined the availability of behavioral health community-based services and gaps in the system of care and offered different options for service enhancement. So the analysis, and we'll talk about this on the other end, but just to underscore that the findings, there is a need of a comprehensive approach to addressing behavioral health crisis in Florida and the importance of policy and service enhancements to meet the needs of our Florida population. And I'll say what's nice about this webinar group and the folks that we work with is that we're not siloed. And so we've done a lot of work with different organizations or with different areas. So working in the arena of policy and research and practice, we all need to come together, even though you may be just in one of those circles. In order for us to really move the needle, we all need to move together to make sure that we're seeing what the need is, and then we can make future recommendations. So also just want to share that the gap analysis, they looked at 6 different regions, and they were broken down into the Northwest region, the Northeast, Central, Suncoast, Southeast, and Southern. And again, that was broken down by both adult and children. And the study really focused on what was already in the system. So this is a lot of information. And again, I think we'll have a slide at the end that will have a link to the actual gap analysis so that you can really read further. We don't have a lot of time. We're doing more of a high level. Here's what are some of the gaps and opportunities. And then if you really wanted more information, we'll have a chat at the end. And then there's the actual report and PDF for this as well. So as you can see here, the The gap analysis broke it down into adults and then children and adolescents. And it looked at the total number of facilities across the state of Florida. So 302 facilities in adults, and you can see there's a lot less for children and adolescents, 93 facilities statewide. And then they looked at total bed days statewide. And then they also looked at, they broke it down by beds. So they broke it down for adults with state mental health, and that included both forensic and civil, residential beds, hospital with psychiatric beds, and then specialty psychiatric hospital beds. And you can see what the current number of beds are, and then right underneath, you can see what is needed. So for residential, there was a range of about 140, sorry, can you go back? Sorry, 149 to 205. Hospital with psychiatric beds was about 189, and then specialty psych beds was 169. And then if you go over to children and adolescents, you can see that they broke it down by residential. So really love the clubhouse model, and we are so fortunate that we have so many across our state, but we could always have more, right? Also, recovery community organizations. So there's lots of RCOs as well within our communities, and peer-led support and programming. Peer support specialists are, we are doing such great work in the state of Florida in terms of enhancing our peers and really trying to figure out certification, figure out where peers are needed. You know, again, those with lived experience, and there's different avenues. So you could have lived experience within mental health, substance use, child welfare, and there's lots of opportunities to enhance and increase our support for peer support specialists. Next slide.
Kathy, if I could, there was a regarding residential beds. Would you take a moment just to explain just briefly what those residential beds are?
Sure. Thank you.
Thank you.
Sure. Thank you, Maggie. And just briefly, because we could have a whole conversation about residential treatment and bed capacity. But in terms of thinking about it from a mental health perspective, there's 4 different residential options. So residential 1 to 4, starting at the more independent level and then going to lockdown. And so each has their own criteria and length of stay. And, you know, this is true for adults and for children. So they're very different in terms of service capacity and service need, as you saw with the beds that we just kind of talked about with capacity. In the substance use realm, it's a little bit different as well. But the bottom line is that the residential funding is, in order to get increased bed capacity, that's just something that we really need to think about, and think about how we can do that in terms of collectively, but also what happens before, what preventative measures can we use before, and then afterwards, aftercare. So how can we don't just think about this as residential beds, but think about it as a more holistic continuum, and how we can work together on the whole system of care.
Got it. Thank you for that. Excellent.
Thank you, Maggie. So just a little bit more on the treatment and community supports. There is, and I'm sure a lot of you are aware, opportunities to expand access to targeted care coordination so that individuals with complicated behavioral health issues, a lot of times folks that come into the system don't just have one issue, whether that be mental health, substance use, physical health, right? There's usually a myriad of issues that go along with this. And so having personalized support, having streamlined navigation of services, having an integrated care plan. So knowing that sometimes it's not just one-stop shopping, but you're going to various providers, but understanding what is going on can help in that integrated care. Also, as I mentioned, expanding the availability of clubhouses by establishing at least one new location in the Northwest region to offer recovery-oriented supports, and to establish a lot more FACT teams, and that's the Florida sort of community treatment team, statewide, to provide community-based services that hopefully can reduce inpatient admissions and prevent readmissions. So we're not just circling the wagon, but you can get the treatment that you need up front and then connect to services on the back end so that you're not continually re-entering the system is very important. And I'm going to turn the baton over to my colleague, Dr. Whitt.
And I have a question for you, Courtney, Dr. We often hear that people can't find a psychiatrist or they have to wait months to see one. We've heard that there's a shortage of behavioral health workers to even fill the positions that are in the existing system. So can you tell us a little bit about the workforce gap and also the work that your Florida Center for Behavioral Health workforce is doing to study this?
Absolutely. The simple answer of why you can't find a psychiatrist is there's not enough of them. And we'll go through just some numbers that I think that'll capture that. But before I do, I want to mention, I think that there is an absolute shortage that we do need to address and are working to address. And we could do better as a profession at educating the community on the type of providers and what their different skills are and the types of services that they are able to provide and how to best navigate the system. Unfortunately, to do that, we have to do a better job of that as ourselves as professionals on defining what are the scopes of practice? How is it best and when is the best time to leverage a psychiatrist versus a psychiatric mental health nurse practitioner or a psychologist versus a master's level clinician? There's a lot of overlap. But if someone's just focusing because what they know is to see a psychiatrist or psychologist, that's what they look up on their insurance panel, they're going to be waiting a long time. And then they might call and find out that those providers no longer participate in insurance because of the reimbursement rates are too low, which is just incredibly demoralizing, frustrating, like how helpless, right? So I think that's something that as a profession that we need to address alongside this, how we put the pieces together in a meaningful way. Looking at the Ernst Young report, so they looked at some historical data and found that in Florida, there was a mental health to patient to mental health provider ratio of 550 to 1. So that means there's one behavioral health provider for every 550 residents. And this is one of the worst in the country. On average in Florida and across the US, that ratio is 340 to 1. And in the best states like Massachusetts, it is 140 to 1. So the lower the number, the better. So Florida definitely has a lot of work to do. If you look by counties in terms of those health professional shortage areas, all but one county, I believe that was Clay County and kind of the northeast part of the state, faced a mental health professional shortage. And based on the models that they examined, we would need an additional 25,000 additional mental health providers to meet the statewide demand. And that's at least 34 psychiatrists to provide sufficient coverage and availability. Part of their work was to meet with community stakeholders and do focus groups. And, you'll always hear related to reimbursement rates coming up. Basically, they're just too low. They haven't changed enough in years to catch up with the cost of living. And so participating in that makes it incredibly challenging to be able to pay a workforce, especially as there's new opportunities that could create access like telehealth, but more safety net organizations aren't able to compete with those kind of wages or the flexibility to really be the safety net for the communities that they serve. And of course, this is the problem that just keeps on giving. When there's not enough people, it doesn't mean that the needs slow down. It doesn't mean that there's fewer individuals reaching out for help. And so that's leading to clinicians having higher workloads, burnout, and how helpless too that they feel knowing, they're trying to schedule an appointment or recommend, following up in 1 week. But when they go to schedule that appointment, there's not an available appointment for 4 weeks, right? But if that's not just one of your patients, that's all of them, it can be incredibly frustrating and kind of lead to that feeling of burnout. So this is kind of some of our individual work, and I'll pause and tell you a little bit about our center in just a moment. But we found very similar to what Ernst Young reported related to the behavioral health workforce. So you'll see here on the left, there's a map of Florida, and it looks at a kind of a 10-year change. So Florida has done an incredible job at growing our behavioral health workforce. So in a 10-year period of time, we increased our workforce in terms of licensed professionals by over 20,000. But our state is also one of the fastest growing. So between 2020 and 2024, I think we are the fastest growing state in the country, and had 8% growth. And so for a system that's already taxed, already has insufficient capacity to add more people in terms of need, at a time when more people are reaching out for services for the first time, it's definitely not enough. And on the right, you'll see our model of the supply and demand. And so that's kind of the historical trend, and what things are looking like going forward in terms of the supply and versus the demand. So on the bottom of there is the supply, and then the demand is on the top. So you'll see that there's a gap. The good news in Florida for a lot of professions is that this has been improving, but just not to the degree that we need it to meet the demand. This example in particular is for psychiatrists, and you'll see that there's not only been really stagnant growth, but that they also have are falling, right? And so that gap is only widening. And so that question of having a psychiatrist and why can't I find one, it is a real serious one that pans out in the data here. The good news is that in terms of what can we do, Florida is already doing a lot. One is by virtue of our center. So we're the Florida Center for Behavioral Health Workforce. We were legislatively commissioned last year in 2024, at the same time this report was commissioned. And we have the very, very tall order of working to grow, retain, and innovate the state's behavioral health workforce. And that is through research and dissemination of best practices, as well as our evidence. That's through education and professional development. So how do we kind of garner interest from the next generation of behavioral health professionals? How do we work on reducing barriers and putting the pieces together to streamline the educational pathway, reduce economic burdens? And then how do we continue to kind of upscale and kind of evolve and educate our existing workforce to meet the needs of the population that are arising, so that they're kind of ready and capable and willing to see what comes before them, and to meet those needs. And the other is just policy analysis and implementation, examining some of the state's policies and seeing, is it having the intended end, or are there opportunities to tweak it a little bit so that we can continue to create more workforce access? The other thing, just related to the same kind of batch of bills, a part of this broader Live Healthy legislation, was the establishment of behavioral health teaching hospitals. And so they had an original 4, and now there's 5 in the state. And they're taking on a lot of new programming, some even related to increasing bed capacity. But they do have a specific charge to kind of grow the number of slots for training for psychiatry residents, as well as for postdoctoral psychology fellows. So really kind of recognizing that that is a severe, severe shortage, and already starting to put a plan in place to help mitigate that. And the other thing that they did was, for the first time, leverage, when something works, like, why don't we just expand it and replicate it? Like, sometimes the solution's just there. And so Florida had an existing program for loan reimbursement for medical providers that was available for those serving in certain community settings, like community mental health or federally qualified health centers, for example. And so that loan forgiveness, if they had a certain number of volunteer hours, they'd be able to get money that they could put to pay down some of their loans. But that wasn't available for behavioral health previously. And so now it has been approved to be for behavioral health providers to be able to draw from some of those funds and apply for the awards. And I hear that we drew down that to $0 pretty quickly. So it's great to hear that a program has been put in place, and that it's being tapped into as a resource as designed. The other is that community mental health centers in particular, definitely other agencies, but community mental health centers have really been providing so much of the training for the next generation of behavioral health professionals and see it as their responsibility. But they also see this as essential for developing their pipeline with the rate of turnover. But historically, that comes at a loss. You need workforce resources to be able to train individuals and provide the time, the necessary supervision and supports. And so there's now been funding that's been available to them. So for basically for being able to be a training site, they're being able to recoup an hourly fee for being a training or for that trainee. And so it's helping with some of that lost revenue from having them. The other thing that we need to think about is that it takes a long time to grow a behavioral health provider. You can't grow them overnight. And we don't want to just focus on growing them chaotically. How do we grow them in really intentional ways? And so I think how do we put the pieces together, looking at psychiatrists and psychologists, but also making sure that we have a workforce that is exists in the settings where people are at, and that they're able to coordinate care and work collaboratively together in the best interest of that individual. So whether that's, again, a school counselor, a social worker, a peer specialist, really working hand in hand and having the full spectrum of a workforce able to serve an individual and family's needs when they need it and where they need it. And the other piece is how do we think responsibly about technology? It's happening whether we're ready or not. And being a behavioral health provider myself, we normally like pump the brakes and kind of think of all the unintended consequences of things first. But we do need to look meaningfully in how technology can be safely used and accessible to our community, not as a replacement for behavioral health services, but perhaps as a reinforcer, or perhaps in helping to streamline and create more efficiencies in the system or reduce more administrative burdens for our workforce so they have more time to train, more time to see another patient and fit them in a slot. And so they're not kind of doing what we call pajama time, going home and then putting your pajamas on, putting your feet up, and then spending 3, 4 hours doing documentation that you weren't able to do from the day.
Courtney, thank you so much for that. I love the pajama time. I wanted just to get a quick question in here. Can you tell us a little bit about how the behavioral health system and the importance of it and the integration of behavioral health with the medical care? How does this relate to the whole workforce that you were just addressing?
Absolutely. Can you jump to one more slide ahead for me?
Sure.
Thank you. And I could talk all day about this, to be honest, so I'm going to try to keep it like short and sweet. And this is something that was a recommendation or an opportunity for enhancement identified by Ernst Young is for more integrated behavioral health. And we do have this in Florida, but there are things that make it difficult to implement. And that's a lot around kind of some of the policy and reimbursement so that certain behavioral health providers can function in certain settings. But really, integrated behavioral health is putting mind and body together and one and treating the whole person and putting a care team together that's able to collectively meet the needs for an individual, all from the primary care setting. There's a lot in medical care that could improve, right? No doubt, right? We get a lot wrong, but we also get a lot right. And one of the things with integrated care is that they really take a population health approach. They incentivize getting an annual checkup, but we don't have the same for behavioral health. And so really building out that full continuum of care and building a primary care behavioral health service can be essential. Um, First, just individuals, they don't know that something that they're going through might be a mental health concern. They might just know that their energy is incredibly low, they're gaining weight, they're not sleeping, and their partner's saying like they've been really irritable and we better get it together or else. But going to a doctor's office, so they show up in primary care. And so the primary care providers can do the necessary things like check the lab work, kind of rule out any medical condition. But oftentimes those can be symptoms of stressors or an emerging mental health concern. And so being able to respond with immediacy and connecting someone to a behavioral health professional instead of waiting until something gets to a crisis because there's no care is incredibly, incredibly important. And so there's different levels of what integrated care can look like. It can be a primary care professional or provider that has a established relationship with a psychiatrist or psychiatric mental health nurse practitioner, a whole range of therapists. They know their insurances, they know they're accessible for their patients, and they're able to make a referral, but also coordinate that care. You know, hey, I referred this patient, they're really struggling on their medication for depression, and so I need your assistance, but I also have to make sure that what you're treating with them with doesn't make their diabetes worse, right? And so they're really working hand in hand for that care. Another kind of more advanced model is co-located. So being able to make that referral, but they're having that behavioral health provider right there on site that kind of has an office very close and kind of within the same building as the medical provider. And so that creates a sense of safety. There's familiarity. We know that the patient and family can already access that level of care. And there's less stigma, right? I could go into the doctor's office. Um, I can go into the doctor's office anytime, and nobody knows the reason I'm going in for. And so that can help make it more safe. And then integrated care is really having a behavioral health provider work hand in hand and side by side with the primary care provider as a team responding with immediacy. And there are existing models of reverse integration so that we have the behavioral health provider that goes actually to community mental health, right? So they're able to kind of get the full person care right there from where they're comfortable. They have routine appointments set and the like. This is just kind of the game of life because we know that life happens. You know, we can twist the little thing and inevitably, you know, like something can come up and there can be a concern or a crisis. And this image really highlights the full continuum of care. And I think our next panelist will really highlight how all these pieces fit together. But my mantra is always that if one of us are vulnerable, we're all vulnerable. And so we need to make sure that we have capacity, we have well-trained workforce, and that we really have that targeted case management and coordination of care across the full continuum of care. So thank you
so much, Courtney. That was really great. And now we'd like to introduce Sheriff Bill Permel. We're very glad that you agreed to be on this webinar. Just a little background about the sheriff. He has 33 years of experience in law enforcement in Charlotte County, Florida, serving as the sheriff of the Charlotte County Sheriff's Office since January 2013. And throughout his career, he's been involved in many committees and boards, both locally at the state level and the national level, including an appointment on the Florida's Commission of Mental Health and Substance Use Disorders. Sheriff Permel continues to bring advancements to Charlotte County Sheriff's Office, working to better the lives of those in his community in the state of Florida. And I just wanted to add that we think that you're just an incredible advocate for the behavioral health system, Sheriff Permel, and we really appreciate everything that you have done so far and hope that you stay involved.
Thank you, Amy. That's very kind of you to say.
Yeah, and thank you. Can you share your experience with having individuals with serious mental health or behavioral health conditions in your jail? And what gaps in services do you think should be filled so that some of those individuals do not end up in your jail?
Absolutely. Well, going back and kind of giving a little bit of history, I've said often that what the federal and state governments can't figure out often falls on the shoulders of law enforcement. And then people tend to get upset when we don't get it right. We have been on the front lines of mental health and substance use for decades. And that's never going to change. I know there's been a lot of talk nationwide about how can we get law enforcement not to respond to these mental health calls. Well, in my eyes, you will never see that change because people, when they see somebody acting irrationally, not acting right, you're dealing with somebody, often you're dealing with people with substance use and mental health issues, and they commit low-level crimes, sometimes, unfortunately, some more major crimes. Law enforcement's going to get called. 911 is usually always the first number that gets called. So you're not going to ever take us out. So we've been trying to figure out a way of how can we be better at responding and providing services to our community. Another unfortunate thing too is not all counties and municipalities are created equal. I'm lucky here. I'm not the richest county in the state, but I'm not the poorest county in the state. And we have great partnerships here within our county with my board of county commissioners and a lot of our nonprofits. And we were able to start our own co-response model. I teamed up with our local CBC, and we have a specially trained deputy that goes with a mental health professional, and they respond to substance use calls and mental health calls. So we're trying to do better on the front end to keep people out of the jails, out of the prisons, because as we're all very aware of, is our jails and prisons are your largest mental health facilities in the nation, and that's got to change. So we're trying to do better on the front end, but unfortunately, they still slip through the cracks. You know, we try to identify, we're doing everything we can statewide to train more and more law enforcement in crisis intervention training so that they have the ability to understand, to identify, and potentially communicate with somebody who is in crisis or dealing with a mental health issue so we can get them to the services they need instead of putting them to the jail. I mean, very traditionally, when we have somebody acting like a fool, if we had a criminal charge, we would throw them in jail and we're like, okay, well, we know we're not going to have to deal with them for a while because they're not going to have any way of getting out of jail. If they don't commit a crime and we can stretch it out to a Baker Act, well, we'll Baker Act them. And we know that if we're lucky, we won't have to deal with them for 72 hours. If not, at least the rest of my shift, I won't have to deal with them. But that doesn't do anything. It creates a burden because, you know, and that was a lot of misconception with law enforcement too, because, and I can even say when I was a baby cop, when I Baker Acted someone, I thought I was getting them help. And that's not what a Baker Act is. A Baker Act is to stabilize somebody. Once they're stable, they're released out. Now we have made some changes over the years with the Baker Act statute where now as they're released, they're referred to resources and to get that help. Unfortunately, it's still up to that individual whether or not they're going to go get that help. Now, here in my county with my co-responder model, we do use our IRIS team to go out and follow up with those individuals to try and coax them and make sure that they're getting into those services. But again, that's not something that happens statewide. And you still have a lot of jurisdictions that don't have any of these type services. I talked to a fellow sheriff up in Franklin County. If he Baker Acts somebody, it's a 4-hour round trip for him to Baker Act somebody because he's got nothing in his county. So there's no resources anywhere in his county where he can refer somebody who's dealing with substance use disorder or mental health disorder. Now, again, getting back into the jail, that becomes an added burden. We found that people who are suffering from mental health issues usually stay longer within the jail, and it takes them longer to get through the criminal justice system. And that jumps into competency restoration. You know, in order for somebody to go through the court system, they have to be competent to stand trial. And if the court deems that they're not competent, they have to go off to a facility to gain their competency. And again, that was another misconception. People think that competency restoration is treatment. It's far from treatment. All competency restoration does, and per the U.S. Supreme Court, it's so the person is rationally able to consult with their attorney and holds a clear understanding of the charges against him or her. So, like I said, a lot of people think that this is a way to connect the person to mental health services, and that's not what it is. It's to get them through the court system. So what happens is if the court deems them incompetent, per state statute, the Department of Children and Families has 15 days to move them into a facility for the competency restoration. DCF, the demand is so high, DCF can never meet that number. You're waiting 3 to 6 months for that person to go in there. And then when they do go, they're gone for about 6 months at a cost of about $50,000 per person. You know, Florida spends nearly 20% of all adult mental health dollars and half of all state mental health treatment facility dollars, nearly $200 million annually on 1,600 forensic and forensic step-down beds. It's about 3,300 people, individuals each year. That's crazy. But when you're dealing with competency restoration, you're dealing with a gamut of crimes. And, this had came, I knew that we were dealing with this and we were trying to do a lot of things. I have a lot of different programs that I do in my jail, out in the community to try and do this prevention, but people still slip through the cracks. And that brings you to Tristan Murphy. Tristan Murphy, unfortunately, happened in my county. With everything I have in place, it still happened in my county. And because of his history, the court's hands were tied with what they can do with him. And ultimately, he ended up getting sentenced to prison. He went down to a prison down in Miami-Dade, and he ended up taking his life in a very horrific way. So this is how I got involved. And Mrs. Murphy, I've sat down with her and her husband, and there was another family just a county south of me that their son was going through the same issues. Now, he was just going through the court system, but he has a very similar story to what Tristan did. And I sat down with both of them to listen to their stories. And I was able to get, luckily, I'm good friends with Senate President Ben Albritton. And I was able to call him up, and he came in right away. He met with me and he met with the families. He listened to their stories. And then we were able to get things going, and the Tristan Murphy Act was born. I also had a lot of help from Judge Leifman out of Miami-Dade. They got a phenomenal mental health program down in Miami-Dade. And he's kind of like the godfather of mental health in the criminal justice system. So it was great to have him on board. But now what we have with the Tristan Murphy Act, which passed this year and just went into effect October 1, is now we don't have to send everybody to competency restoration. When we're dealing with low-level nonviolent felonies and misdemeanors, if they meet the criteria, when they're arrested, they come in and everybody's evaluated within 24 hours. So once they're evaluated, we know if we're dealing with a mental health issue, we're dealing with autism or the like. And then we can contact the state's attorney's office. All of this information is provided with them. And then it works through the courts where they can set up mental health treatment, not sending them to jail for an extended period of time, not sending them to prison. But often many of them we're hoping will qualify for out treatment, but the courts will still have say over it. They will be able to oversee the treatment. So if this person is not going through it, we could still pull them back in and we can be a little bit more forceful. But this is really trying to avoid that issue where we're sending all these mental health people to prison, because that's the worst thing you can do for somebody with mental health, because they will deteriorate even more. So I'm very excited about this. I've already had meetings with our SAO, with our public defender's office, with the chief judge, and with the court system to start our program here with the Tristan Murphy Act and how we're going to get this rolling. And we have our local CBC is also involved in the conversation. So we're hoping that this is going to divert a lot of people out of our prisons, out of our jails, into treatment where they need to be. And in the long run, it's going to save a lot of taxpayer money, because as I told you before, we're throwing a lot of money away for these competency restoration programs that do nothing.
Just want to thank you so much, Sheriff Fromell, just for your passion and your dedication. Used to watch you, when you were chairing the commission and listen to you. And we know that you have been just a dedicated hero in the whole behavioral health, system of care. And thank you so much for your insight and just sharing that important information with our viewers today. So I just want to ask Kathy and Courtney, after Sheriff Fromell has shared all this with us, and you have shared the the report. So what's next for us? What can we do as far as this analysis is concerned? And how is this going to be used in any way to change the system of care within our state?
Mm-hmm. And Courtney, I can start, and if you want to follow up, that would be great. So thank you, Maggie, and thank you, Sheriff Fromell. Just your words, I know, resonate with so many people that are on this webinar today, and I know that you just don't talk, you also walk and you take action. And to see somebody struggling within your community, and then to really, that's what I was talking about earlier with kind of the policy research practice continuum where we all need to work together. You put this into action and created the Tristan Murphy Act along with his family. And so that's just the support that you give your community, but also statewide in terms of sharing what's going on is so invaluable. And I'll say, Maggie, to your question about what can we do next, in addition to, again, all collaborating and working together in a coordinated system, you mentioned the commission that Sheriff Mel did chair. As part of that commission, there are several different subcommittees, and I chair the data subcommittee. And we've been working for several years on trying to get a recommendation in place for a statewide data repository. That actually was in the same legislation as the Tristan Murphy Act, and the governor signed that at the end of June. We just got funding, actually October 1, to put this in place, and that is going to be under the Northwest Regional Data Center up at Florida State University. So they already have collaborations across the state with different state agencies. And so the idea is to really think about connecting some of these data, so such as ACA, such as DCF, DJJ, Court, different entities across the state where a person may enter, right, a different door at a different time. And to be able to think about, when we think about coordinated system of care, data always comes up. And so being able to show not just what's currently going on and what is needed in terms of what we were just talking about with the gap analysis, but to also look at trends over time and seeing what, maybe what was working in the past and how we can continue doing that. If something's not broken, we want to continue doing it. But also, with anything, there's new drugs that are on the market. There are different pockets of people that are not getting the care they need, both behavioral health and other health care. So thinking about what we can do in the future and how we can use data in a wise and efficient manner, I think having this repository will be great. So we just started, but I can see that this gap analysis can be used in a way that will kind of taking this and then forwarding the momentum and thinking about some of these recommendations that are in here and utilizing them for the repository. Courtney, if you want to add anything.
No, I don't have much to add. I mean, I absolutely think, advocating is essential. And, being able to see what comes out in the legislation, you're able to see kind of what is on the radar of those around you. And I think from everyone's vantage point here, they have unique perspective into the opportunities and needs. And so how to kind of follow up with your legislators and tell stories and really kind of give insight into the human and real life kind of like impact of this. And the cost of it too, some of that data.
Yeah.
I think the other thing too is like, how do we highlight what is working right too? If there's like model programs, model kind of coordinated systems of care, how do we kind of elevate that and demonstrate that to maybe start to have that ripple effect to changing systems across Florida?
Yeah. And I think, Sheriff Promel just the story that he told in terms of, there was a situation in Charlotte County, working together with the family, going to the legislature. I mean, that is what is needed. So being able to really work with different parties, as we said, and being able to not just tell your story, but to use that story for the good, I think is really important. And so really, what the Florida Mental Health Advocacy Coalition is doing, grassroots, and really pulling together different professionals in a way that where we can, like we said earlier, where we can move the needle is very, very important.
And we have this slide up and we're talking about what can we do, maybe the family members and the peers out there who are going through their own experiences. Anybody can call their state legislators. Very easy to find them online. And you can talk to them about what's happening to you In your experience, whether you're a mental health professional or a family member or a peer, next week is Behavioral Health Day in Tallahassee. And we're going to have a whole group of people up there from the Florida Mental Health Advocacy Coalition and other organizations. And we're going to be talking to legislators. We're going to bring information about the gap analysis to them. And so we wanted everybody to just be aware of this gap analysis so that they can refer other people to it. Just, it's not a complete gap analysis, but it's probably the most complete that we've had in years, decades, probably. So in telling your personal story, as Kathy mentioned, is really key to making that personal connection with the people who make the decisions. So we're ready for questions. Gail, you can't see the Q&A, right? So I can go ahead and see.
Yes, and I want to thank you all for being here and apologize for our technical difficulties today. Amy and I have both had internet problems, but I'm really happy that you've stuck with us, and I thank Sheriff Pramell and Dr. Courtney Whitt and Dr. Kathy Moore for doing an incredible job. Thank you.
So let's see. Oh, there's somebody who has written in to talk about the importance of having a psychiatrist who can prescribe clozapine, which she is explaining that her son, it's a very effective medication for her son, but she can't find somebody in her county. I think she finally found somebody to prescribe that medication. That's really important, to find the right medication that works for somebody and to have a practitioner who can prescribe it and who will prescribe it.
Actually, I have a little bit of information on that. The group called Team Daniel. Team Daniel was started by Dr. Robert Layman, and Daniel refers to his son who has schizophrenia. And Team Daniel is all about running for recovery, but also Dr. Layman is a clozapine expert. And if you go to Team Daniel on Facebook, you can find a list of prescribers across the nation that will prescribe clozapine.
That's great, Gail. Another person is just saying thank you for doing this, and is saying this is Stephanie Breedlove from Discovery Behavioral Health, and she works with adolescent residential treatment for ages 11 through 17, all genders, primary mental health, and co-occurring substance use disorders. Let's see. Oh, okay. Teresa is asking, has anyone looked into healthcare systems across the state, as well as law enforcement systems, having a shared system to see the history of individuals throughout the state? I think, Kathy, this has to do with what you were just talking about. Our experience having someone on the street with severe mental illness. It's Baker Act off the street for 72 hours, hold, then back on the street, sometimes going to another county, and several different long-acting injections are administered less than a month. You want to respond to that?
I mean, I think it just, speaks to some of the gaps in our system. And so I think the part of the question too was being Baker acted and then going back, she says, going back on the street, sometimes going to another county. So that's also, can be problematic when you're maybe getting care in one county and you have a provider, but then you go to another county and there's no communication between providers. So again, being able to share information, I think, is really important, and to to understand and sometimes the person may not even know what provider they may have been to, or the different types of medications, and so it can get complicated. But I think just having that coordinated system, I think, will help in the long run. But being able to share information, I think, would be key.
Yeah, absolutely. I mean, there's a big gap when we're talking about Baker Act. Even neighboring counties, I could Baker Act somebody here, and then they can go to a neighboring county, be Baker Acted there, and nobody's the wiser. So they can't
Right.
communicate with one another, find out what one did with the other, and try and provide the best services. So that's it. There's too many silos in this state, too many.
Mhm.
The most recent Baker Act did include that family members who are engaged in their loved one's care or other advocates could be peer specialists need to be involved in that discharge plan. And it does put a bit of a burden on the discharge planner at the Baker Act facility, but that would make a huge difference for those people who have that support system. Because I really don't think we can expect people after 72 hours to be able to get their medications filled and make it to that therapy appointment and so on. But if they have that support team, then it can happen.
Deborah asks or says, we have an awesome mental health court in Marion County, but our folks are not getting their interviews within 24 hours of being in the jail. And that is causing a huge problem. Any suggestions?
Well, the mental health in reference to the 24 hours, unfortunately, one of the things within the statute is it's not mandatory. The counties have to opt in, and the law just went into effect October 1. We haven't got it up running here in Charlotte County yet. We're working on the process because it does cost money too. So I have to increase my budget when it comes to my mental health. I'm sorry, I just lost my train of thought. In reference to my mental health services within the jail. So it's going to increase the amount of time my mental health professionals there need to work, because they're going to have to assess everybody who comes through that door. So there is a monetary budgetary issue that comes to this with each county, with each jail. And like I said, that was the only unfortunate thing with the Tristan Murphy Act, is the counties do not have to do it, but they're strongly encouraged to do it.
Interesting. Deb asks, can we get a copy of the PowerPoint presentation and we will be able to watch the recorded presentation again? Yes, you will. We're going to post it on the Florida Advocates for Behavioral Health website. You'll see the link at the end. Let's see. A lot more questions here. Hold on just a minute. Avery asked, do you have any concerns related to the criminalization of homelessness in DC and the domino lack of beds leading to jailing in for-profit prisons while we are already low on beds?
Well, I can't really speak intelligently of what's going on in DC, but I can tell you we do have a homeless problem here in the state of Florida. I have it here in Charlotte County. Unfortunately, you do have a lot of homeless people that do get involved with criminal activity, and that's where it's going to be important that, and I hope that a lot of the counties, if not all the counties, do get involved with the Tristan Murphy Act, that will be able to get those person services, because the majority of your homeless people are dealing not only with substance use disorder, but mental health disorders. I mean, that's what happened many years ago when the state hospitals closed, and that was even before my time. They let everybody out of the institutions, but there was no plan. So they all ended out on the street. And that's no different today. Many of them are out on the street. I know that I have a very large portion of our homeless population that want to be homeless. They want to be left alone. They just want to stay out there in the woods. But they're also causing problems and havoc to businesses and neighbors. So we have to deal with them, and we're trying to deal with them the best we can without trying to criminalize homelessness.
Difficult.
Yeah, I think Sheriff Permel, it also speaks to the, you mentioned the co-responder model team that you utilize in Charlotte County. A lot of our counties are, have what we call, co-responder or behavioral health units, where a clinician and law enforcement work together. And so in that regard, you're going out, and each county actually may work a little bit differently, but it just may expand the knowledge. And part of that is to possibly divert from Baker Act, divert from jail. And so the more that we can, again, coordinate, working together, because we assume, law enforcement, as Sheriff Permel said, that, it's not, you're going to still have people that are going into jail that primarily need mental health issues, substance use issues. And so we ask a lot of our law enforcement officers on the street every single day. And so being able to have additional support for patrol and services that are going on, I think is much needed. And so one opportunity for that is having these behavioral health units that we can expand across the sheriff's office and the police departments.
Angela asks, who and how can Florida start a master's in mental health advocacy to educate all, help and end stigma, and speak with authority to groups as a knowledgeable speaker? And Angela is the 2004 Clifford Bills winner from Mental Health America as a lawyer with bipolar disorder working to educate Florida lawyers and judges. Interesting question.
I love it.
Yeah.
No, I would love to look into other programs that exist and how other states are approaching it. Typically programs are around kind of health policy or kind of public administration or kind of going the legal route, but there's not always kind of that clear route for advocacy or having a meaningful impact in policy. And if there is, how many of those, especially those in Florida, have an expert or kind of curriculum related to the mental health space and how to approach that? So you piqued my curiosity. I'm sold on the idea and would love to look into it further.
I think that's great. I will say, we have an undergraduate program in behavioral healthcare that does speak. We have courses in recovery where we talk about stigma and we talk about advocacy. It's kind of spread throughout, but that's at the undergraduate level. It would be great to be able, Courtney, to continue at the master's level and maybe even think about having a certificate on mental health advocacy.
And NAMI, Florida offers the NAMI Smarts for Advocacy class. It's about a 6-hour virtual class and it's free, and they offer it maybe 4 times a year.
Yeah. I wish we had a degree. Jackie writes in, thank you, everybody. Just wanted you to know we are offering a full scholarship for as long as it's needed for somebody with serious mental illness for supportive housing services here at Premier Wellness of South Florida. And she has her, it's pwsfliving.com for more information. That's interesting.
That's fantastic. And I just want to do a plug for supportive housing because there's been several pilot projects done in Florida for people with high needs, who are dealing with both mental health conditions and substance use and in and out of jail. And some of them went into a pilot program in Jacksonville, for instance, and got connected to housing right away and to the wraparound service, supportive services that they needed. And, were quite successful, moved on to recovery and getting jobs and so on. So we know that supportive housing works, and it's actually much cheaper than putting someone in jail, certainly cheaper than putting someone in the state hospital. So I think we just need to expand supportive housing in our state. And in regards to the question on homelessness, though, I think that the problem is affordability of housing mostly. That's probably the greatest cause. We're seeing a huge increase in elderly people becoming homeless because they just can't afford the raises in their rents right now. Thank you for that question about the homeless population, and thank you for Premier Wellness. That is very interesting, and I'd like to learn more about your supportive housing.
Francesca asks, for the discharge planning, should a severe mental health diagnosis, a person with a severe mental health diagnosis, be put in a residential facility with people dealing with coexisting addiction issues, which often happens? Anybody have any?
I mean, I think it's hard to uncouple those. So like we were saying, a lot of times folks with a mental health issue oftentimes have a co-occurring substance use issue, physical health issues. And so, I think that there's different types of treatment modalities. But oftentimes you want to work in, parallel treatment. You don't want to just work on one issue and then the other. And so, I think that, but somebody with a severe mental illness, Courtney, are there specific, do you know any facilities that are focusing on just severe mental illness?
Not off the top of my head.
Yeah, it's more of a continuum.
Hmm.
And I think, a lot of, again, just going back to the training and education of our workforce, we want to be trained in both, right? So oftentimes we have students that I just want to work with this population or with kids or adults or, just with addiction and you have to, in this state, you have to be willing, you have to share the wealth and understand how all of these systems interconnect. I think it's really important. Because if you're just wanting to work with children, but you're going to have to work with parents, right? And if you just want to work with somebody with substance use issues, oftentimes there's a mental health diagnosis underlying that. So, I think as we move forward, we're probably going to see more and more of that and all of these different systems interconnecting.
Yeah.
I will say that I hear a lot from moms like me who have kids with a serious mental illness that don't have a substance use disorder, and I do know that it's common to have both, but there are many treatment centers that say they do both. When it tends to be more focused on one or the other, and honestly, usually substance use. And then when you have someone with SMI that needs really good quality care for something like schizophrenia, schizoaffective disorder, or bipolar, major depression, and you need psychiatrists and therapists who are quite experts in those areas, and you may not have them in a facility that's focusing just a little more on substance use. So I'm just gonna say I hear that.
Yeah, I agree with you, Gail.
Our policies don't help the matter. We have a chapter on mental health and a chapter on substance abuse and associated policies and who can practice and what ways for a scope of service and scope of practice at what level. And so make that make sense, right?
Right.
Because we can't put one person in one category and one in the other. They
Right.
coexist. And if it's good enough in the system, why isn't it good enough in the mental health system or vice versa? And so how do we have more parity and between those and bring them together meaningfully under kind of a broader chapter of behavioral health?
Yeah, Courtney, to that point, we wrote a grant 20 years ago, a community action grant, and that was the focus, was to really bring together these different populations, and we're still talking about it. So I think it's still an issue moving forward.
Yeah.
Thank you for that question. That's a really good question, really important.
Jackie from my colleague NAMI has a question. And I was actually in this meeting that she's talking about. A local legislator is looking to take on the issue of Baker Acts appearing in background check investigations. And she says, from my experience and research, I know that Baker Acts, although civil matters can show up in background checks for professional licensing if there was a law enforcement component. Is this generally the case? Does it depend on the level or the type of background check? We'd like to find out what it is so that we can inform his office on how often this occurs. And does anybody know whether a person who is Baker acted, does this show up in a background check? Level 2 background check?
I would say a normal background check, no. Now, when you're dealing with law enforcement, if say I'm doing a background check and I contact an agency where they lived or around where they lived, and they can send me a police report, the police report, if they were Baker acted, will show up because that's not a protected under HIPAA. So that will show up with regards to police reports, but not from Baker Act facilities. You won't get that record.
So
Now, I
that's
would think that the Baker Act should discount somebody because a lot of people sometimes they have something happen and they just go through a crisis situation. You know, I have deputies here who have and are suffering from PTSD, and at certain times they had been Baker Acted, and you know that's just to kind of get them stable and get them treatment. But many of them have been able to return to work. So I don't think one Baker Act or so should be a stigma. So somebody should not get hired for something. I think you really need to take a deeper dive.
And I would like to, look into it further. There are new background checks. They're kind of level 2 background checks for providers, and like fingerprinting now coming, through the licensing board at initial license and renewal. But I, echo the sheriff. I don't believe they should be showing up in that kind of criminal background check, but I would love to verify. But when someone does apply for licensure, there is a questionnaire related to their health history and criminal history. But within the health history, there is a question, a self-report related to prior hospitalization. And so that's something by submitting and signing that form, they are attesting to their honest response in that. And I'm not a representative of the board. I just, attend meetings. And so hearing them, it's not a one and done. There's some context building, understanding where an individual was at, where they're at now, and what is their recovery plan and their support system to support them kind of in this next professional journey as they're, kind of moving into the world of becoming a helping professional. So I don't see a hard no, but it's something I'll definitely look into, just so I feel more confident in saying like, absolutely not. It should never be on someone's record. Well, it shouldn't, but I don't know,
Okay, I think that's all of our questions. We have a lot of thank yous. We have somebody who is Ashley, an LSSW for the police. She's the police social worker for the city of Miramar. And she wants to share this with her colleagues, which is great. So thank you to the attendees for your great questions. So I would like to thank our sponsors again, Newport Healthcare and Alkermes. We're very glad to have sponsors of this webinar, which help us keep moving with our work. And also, I'm so grateful to the three of you, Dr. Moore, Dr. Whitt, and Sheriff Connell, for making this a really interesting webinar and really helpful for people who want to know more about our behavioral health system and what's going on. If you want to access the entire gap analysis, if you can take a picture of this QR code and it will take you to the document. We'll leave it on for just a minute. And if you're interested in learning more how to become a behavioral health advocate, please join the Florida Mental Health Advocacy Coalition. We've got a really powerful group of organizations and individuals who are doing great work in their communities and also at the state level. The website for the coalition is flmhac.org. And you can also join our meetings, the Florida Mental Health Advocacy Coalition meetings, which are held every other week or every week during the legislative session, to find out what's really happening at the legislative level. And Gail leads those, and she is an incredible source of information and leadership. So if you enjoyed this webinar and believe in our mission, please visit our website and sign up for future webinars. And also consider making a donation of any size to floridaadvocates.org. We're tax deductible donation, and we'd really love to have your support. So thank you all so much again, and I hope you all have a great rest of the day.